Welcome to the May 2025 Talk with the Doc with Dr. Timothy Leichliter of Allegheny Health Network. Thank you as always. This comes up fast. We really appreciate your time and take it away, Dr. Leichliter.
This one did seem to sneak up. I don't maybe because it's the first. I don't know.
Yes.
I feel like we literally just had one, but well, I also lose track of time. I went on vacation, then I was on call, so I have no idea what day it is or where I'm at right now. But I'm going to do my best. So welcome to the party, everybody. I'm Dr. Leichliter, sitting here in my office at Allegheny General, hoping it doesn't storm like it did on Tuesday. Yeah, glad to see at least some people have power back, although I know not everybody does. This is a good talk with the doc. Good question and answer session. So if you're new to this, welcome to the party. If you're old to this is old news. You know what to expect. If you're new to this is a good place where you can ask questions, and I will give you the best answers I can make up or come up with on the spot. The caveats I usually throw out is this is not a good place to get individualized treatment. So if you have an individualized question, you should probably bring that up with your own neurologist, your own doctor. And everything you hear is my opinion. So I have a lot of opinions. I generally share my opinions fairly freely. I will give you the best opinion I can come up with, but nonetheless, it is my opinion. If you go to somebody else, or if you see another neurologist or another movement disorder specialist, they may give you another opinion. I like to think my opinions are based in as much fact as I can come up with, but sometimes I do have to make stuff up, and I will let you know when I am indeed making stuff up. I actually didn't get a whole lot of questions in my inbox in the email. I only got like 3 or 4. So feel free to type some questions in the chat box. And if it stays light, then we'll just end early. We got some sort of apple cinnamon tea going on today. I didn't really look at the label. All right. The first two that I got were actually kind of website things. So one was, what are my thoughts on a new blood test? So there was I was reading through this research paper. I think this was the one out of Israel, where they were developing a different type of blood test for Parkinson's disease, and they were basically studying or looking at these tRNA derived fragments or TERFs. And this is a small class of RNA molecules that apparently have a certain signature or a certain molecular changes in the very earliest signs of Parkinson's disease. So the long story short is, could this be an early test or an early way to diagnose people with Parkinson's disease? Maybe. I definitely think just in reading what they've done so far, I think there's more work to be done to prove this or test this. But I don't want to say my concern, my caveat, my thought is great, but I'm not sure that necessarily helps me right now in day-to-day practice. So at the end of the day, no matter how early I can diagnose somebody with Parkinson's disease, I still can't do anything about it necessarily. I can tell you to exercise, but I'm pretty much going to tell you to exercise no matter what you have, or you may potentially have. But right now, I don't have a disease modifying medication or therapy or anything that really alters that course. The only thing that I know does that or think does that is exercise. And so, even if I had a test like that where I could test people and say, oh, you are going to develop Parkinson's disease in such and such time, you should go exercise, be healthy, have an active lifestyle. That's really going to be the recommendation. Now, again, that may be useful in research, right? The idea is that maybe if we can find people earlier and we can start testing some of the interventions earlier, maybe we can really pinpoint or find a modifying medication or something that does slow down onset or progression of disease. And so I definitely think, even though I don't think that type of research or that type of test helps me in day-to-day practice, I do think that kind of science or that kind of research does help further research or us to get to where we want to be, which is identifying people earlier and testing things in that population to see if we can find disease modifying medicines. And so my thoughts on stuff like that is, A, more to come. I always want to see more research. I always want to see more evidence. And B, that's great from a research standpoint to try to help us where we're at, but in day-to-day practice, probably not going to be all that beneficial, at least for the moment. The second question was another article where they asked my opinion, which was a dramatic rethink of Parkinson's offers new hope for treatment, which I thought was they always put these catchy titles on there to make everybody get excited, and then you read through it, and then under it is mounting evidence suggests there might be two separate types of the world's fastest growing neurological condition. So long story short is I don't actually have access to the whole paper. I only have access to the first part of it. But this gentleman came to the aha moment about 20 years ago that some people with Parkinson's disease have early REM behavior sleep disorder. And so REM behavior sleep disorder is acting out dreams, yelling, kicking, fighting, screaming, throwing yourself out of bed. And this is not new. This is not new news. We've known that REM behavior sleep disorder is a precursor to people with Parkinson's disease or the alpha-synucleinopathies, particularly Parkinson's disease, Lewy body disease, and multiple systems atrophy. And we know that there is a high percentage of people that are diagnosed with idiopathic REM behavior sleep disorder, meaning they have this underlying sleep problem. A very high percentage of those people are going to go on to develop some sort of Parkinson's-like condition. We have papers on this. This has been studied. We know this. And so his aha moment came to the realization that some people with Parkinson's disease have this problem and some don't. Therefore, there must be at least two different types of Parkinson's disease. That is not earth-shattering news to me, because at the end of the day, everybody has something a little bit different. There's probably 1,000 different types of Parkinson's disease. And I will go back to something that I've thought a long time, which is Parkinson's disease is not actually a disease, it's a syndrome. And I mean by that is it's really a collection of symptoms. Anybody who has the right symptoms in the right setting gets labeled as Parkinson's disease, but we're pretty confident it is not just one thing. It is a combination of a lot of different things that all ends up looking the same. That means you and you and you do not have exactly the same thing. We know this. We know this pretty well. So when I read something like that, I'm not really that impressed. I'm not really that excited. I don't think that really helps as in any way, shape, or form. But again, it does make for a nice title, a nice grab your attention kind of thing. Again, I really do think there's a lot of different types of Parkinson's disease, or a lot of different things that we ultimately end up calling Parkinson's disease. And while on day-to-day practice, that's not really that important, but eventually it hopefully will be. And what I mean by that is the gold standard, or the kind of holy grail of what we would love, or so-called precision medicine in medicine or neurology, would be you come to my office, I look at you, I think you have Parkinson's disease. I then send you for a panel of tests to tell me what specific type or what specific genetic markers or environmental triggers or what specifically led to your Parkinson's disease. And then I go to the cabinet and I come up with a medication that is specific to that specific type of Parkinson's disease. Again, that is not available today. That's the holy grail ideal scenario, hopefully, of precision medicine down the road. But that's generally the idea. That's when it's going to be important that we're able to tease out these different types or different causes. We just can't do that yet. Again, we know some about genetics in Parkinson's disease. We're learning more and more about the environmental triggers. That's hot topics in every conversation in movement disorders, but we haven't been able to put it all together. I can't look at you and say specifically, this is what led to your Parkinson's disease. And until we can do that, it makes it a lot harder to really come up with the use specific treatment and or a fix. Again, I'm hoping someday we're working towards that, or we're going to get closer to that, or we're ultimately going to achieve that, because that makes all of our jobs and lives better, but we're still not there yet. So again, that's kind of how I extrapolate from that paper what he was trying to get at, although I couldn't read the whole paper, so I could have missed a very important part of it. But again, nothing that I think necessarily changes our conversations or day-to-day practice. And then the last two questions that got sent to me just a little bit ago are: one, have you experienced any drugs that you feel might have contributed to some cognitive issues, and then when stopped, these issues improved? And the short answer to that question is yes. Um, and then I'll get to the last question in a second. So yes, all medicines have side effects. I do not have a side effect-free medicine, and some, or I would say a handful of medicines definitely can make cognitive issues worse. The ones that come to mind are medicines like Klonopin. I use Klonopin in a lot of my patients. It's clonazepam. It's a benzodiazepine. It's the treatment of choice for REM behavior sleep disorder or sleep problems. It's a good anti-anxiety medicine. I prescribe it a lot, but it is well known to be a downer and cause cognitive dysfunction. And so ideally we keep the dose as low as possible and we try not to use it unless we have to, but if you have to, you have to. But that's one that comes to mind fairly quickly. The other ones are ones I don't necessarily use in a lot of my Parkinson's disease patients, but I'll use them in more of my dystonia patients, although they are old-fashioned Parkinson's disease medicines. And these are medicines that actually work on acetylcholine more than dopamine. This would be trihexyphenidyl and benztropine. Again, I use these medicines even though I am well aware that they cause cognitive decline, cognitive dysfunction, brain fog, and memory issues. And so the short answer to your question is yes, I do indeed prescribe medicines and I have medicines that I know can down, cognitive function. And yes, sometimes when I stop those drugs, cognitive function, brain fog, mental kind of abilities do improve. The hard part is again when I'm using those medicines, it's usually because I don't really have any other better choices. It's not because I go to those medicines because I think it's fun to try to give you cognitive problems or dull your senses. It's because really these are the best drugs that we have. And this gets back to the fact that everything we do in clinic, everything that I do for my patients, everything that we do when we're taking care of people is really very individualized. What I do for you may not be what I do for the person in the box next to you or the box above you. In fact, all three of you may get something completely different, even though when you're talking to each other, you may say, hey, we all have the same thing. But everything that I do in clinic or when I'm taking care of a patient or managing a patient is really, really individualized for that person. We're trying to solve a specific problem and we're trying to figure out what is the best and or easiest and or least disruptive way to solve that problem. And the answer for you might not be the same answer as for the person next to you. And so, again, when we're picking and choosing which medicines to use, we're trying to come up with the best choice of medicine for a specific problem that hopefully has the least amount of complications, side effects, and issues. Not always easy to do, not always possible to do, but that's kind of what we do. So you may be looking at your, wait a second, I'm on clonazepam. And he knows that medicine is causing some of my cognitive dysfunction. Yeah, that's probably true. But again, if that's the best drug for whatever we're trying to accomplish, then that's what we're going to use. And we just have to accept the price that all medicines potentially come with. That does not mean take everything that I say and give you for gospel. You should always question, hey, remember I'm having some cognitive dysfunction. And you said in your talk with the doc that, this drug could be one of the ones. Definitely bring it up and we should talk about it. And if there is some other way we can try to manage it, I'm not against rethinking even my own plans that might have been from 3, 6, 12 months ago. And so this is where communication and conversations with your treatment team, your doctor, your provider is really important. And again, the conversation may go, no, I mean, I get what you're saying. I hear you. I understand that, but this is still the best drug for what we're trying to accomplish. And we both agree that the risks outweigh or the benefits outweigh the risks. This is what we're going to continue to do. But again, it does open lines of communication. You should always keep that conversation going with whoever's giving you the medicines. The second question in this box was, when do you prescribe Rotari for your patients? So Rotari is a longer lasting carbidopa-levodopa. Carbidopa-levodopa really being Cinemet, really being the gold standard drug that I have for Parkinson's disease, really the best medication that I have. Not the best treatment, exercise is the best treatment, but the best medication that I have. Carbidopa-levodopa comes in a bunch of different varieties. So the immediate release is probably the one that I use the most. This is the one that's been around the longest. It's the most tried and true. It's probably the best version that I have. But it's not the only version that I have. And one of the big downsides to that version is it really doesn't last very long. 6 hours when you start it, maybe to begin with, but I would say as the disease moves or as we try increasing the dose, you're lucky to get 4 hours out of a dose of Cinemet. Cinemet comes in a controlled release. So Cinemet CR has been around for a really long time, and it does last a little bit longer than the immediate release does. So maybe if you get 5 or 6 hours out of a dose, it's better than the immediate release that maybe you're getting 3 or 4 hours out of, but still not tremendous. And the downside to Cinemet CR, in my experience, is that people don't really feel it work as well. I have a lot of patients that really like to feel their pills work. They feel it kick in. And the controlled release just doesn't. And so this is why in my office, I don't use a whole lot of the Cinemet CR during the day because people don't like it as much. I'll use it at night when you're sleeping and I need it to try to wrap around to the morning, because when you're sleeping, you generally don't need to feel it kick in or feel it work as well. But I don't like to use the Cinemet CR during the day because it's not as effective or people don't feel it work as well. I do sometimes, and there are certain circumstances where I do, but not as much. Because of that fact, Neil came up with the idea, well, what if we just put both in one capsule? So they took some immediate release beads, they took some controlled release beads, they put it in a capsule, and they called it Rotari. And the idea was that, it would have immediate release in it, so it would kick in, people would feel it work, they would like it, but it also had the controlled release aspect to it to make it last longer. That's really the definition of Rotari and Crexont for that matter, made by the same company. And so in my experience, when I'm trying to figure out how do I get somebody, how do I prevent that wearing off? You're taking your Cinemet 4 times a day, but it's still wearing off before the next dose. Would something like this help you do better? Cinemet's helping, the immediate release is helping. Maybe it's not good enough. Maybe I need to adjust it. Would Rotari give me a little bit more dosing availability and allow us to try to smooth out ups and downs? Same thing is true for Crexont. These are the newer versions of carbidopa levodopa, and that's probably where you'll see me use it the most. Or if I have somebody where I'm trying to get better control overnight, these longer lasting versions might help. Or I have somebody who's taking carbidopa levodopa, the immediate release, every hour, every 2 hours, 6, 7, 8, 9 times a day, which I have, not ideal, but I have. Could we get away with Rotari or Crexont and back it down to 5 times a day or 4 times a day or even 3 times a day to simplify drug management or regimens? Because I am well aware that the more times I ask somebody to take a medicine, the less likely they are to do so, the more complicated that is. And so there are different places, different times, different ways that I'll try switching to these longer lasting or different versions of carbidopa levodopa. That's by no means an exhaustive list of when I would use it. But that's when you'll see me prescribe Rotari, Crexont, some of these other versions. Again, it's really tailored to the specific patient and what specific problem I'm trying to solve. Again, everybody is a little bit different, but depending on what we're trying to do, that might be a reasonable option. And that was the end of my emailed questions. So now let me go up to the top and I'll see what I can do. Does the medication exacerbate the disease while it reduces symptoms? I don't know what you exacerbate, but I'm going to answer that question in a bunch of different ways. So the medications definitely come with their own price. They definitely can cause some symptoms. So you can get dyskinesias or squirmy movements, you can get hallucinations, you can get fluctuations. Those are all side effects of the medicine. So that's one way I would answer the question. The second way I would answer the question is historically, if you go back and look at research published 50 or 60 years ago, there was a paper that was written that showed in a cell model, I think, or an animal model, carbidopa levodopa actually increased the speed of progression. It actually damaged the dopamine producing cells that were left in that cell line and made the disease progress faster. And that's where the whole idea behind, or that's where part of the idea of delaying the use of levodopa, using dopamine agonists, so on and so forth, first came about. Was there was historically an idea that perhaps carbidopa levodopa was actually toxic to the brain, to the dopamine producing cells, and it actually sped up disease progression. That has pretty much been debunked. There's been multiple papers written about long-term use of carbidopa levodopa, measuring dopamine producing cells or autopsy data to suggest that it does not actually speed up disease progression or is not necessarily toxic to the human brain. And so I would argue that most, if not all, people in the movement disorder world do not think that carbidopa levodopa speeds up disease progression or is toxic to the brain at this point. Um, the other thing to keep in mind, and this has been less written about, less studied, this is just kind of a thought process that's going on, is carbidopa levodopa is not doing anything to solve the problem, right? It's not fixing the cells that aren't there making dopamine. It's not healing the cells that were damaged and helping them produce dopamine more. It is simply replacing the chemical that's missing. And so could theoretically, if you are replacing dopamine artificially, could that suppress the brain cells that are still functioning from making the dopamine that they should naturally be making? Meaning, if I'm supplying your brain with dopamine, is that going to shut off your brain's natural ability to make dopamine, thereby exacerbating the disease? And this has not really been studied or looked at as much as far as I know. I don't think we have any evidence that it does, but it is some idea that's thrown around or talked about occasionally, and it's something to at least think about. Again, it doesn't change anything we do. It wouldn't alter my decision-making process from what I'm going to do for you if you come to my office with Parkinson's disease, but is at least something in a research world or in a academic circle people will talk about. And I don't think there's any good answer to that question. Again, I don't think anybody is holding off using carbidopa, levodopa, or any of the medicines because we're afraid it's going to be toxic or shut down your brain. We're still going to treat you with medicines to see if we can get you doing better. But it's definitely an idea that I've heard talked about, and I'm not sure there's necessarily an answer to it. So hopefully one of those answers answered whatever question you were aiming for with that one. Any good questions for working through mental fatigue? I'm still working and it seems like I'm continually getting behind. Just looking for my opinion on suggestions for working through this. Fatigue is literally the number one complaint or issue that I have in my office. The number one symptom that I hear about is tiredness, fatigue, lack of energy, lack of motivation, which encompasses a whole lot of different things I do recognize. But I think it all circles back to this. And what I mean by that is I have not seen papers on this either. I've not seen publications on this. I only know this from what patients have told me, and I've extrapolated myself. Is the fatigue that people complain about or have trouble with or suffer with when they come to my office is not a physical fatigue. This is not a I just ran a marathon and my body is tired kind of fatigue. This is a mental fatigue or a brain fatigue. And what I mean by that is for patients with Parkinson's disease, every little thing requires extra brain power. There's nothing that you can't do. You can control your tremor. You can swing your arms when you walk. You can talk at a loud voice. You can sit upright. You can do everything. It's just you really have to think about it. You have to put forth a lot of brain power, extra brain power, things that, Casey or me take for granted. For instance, if I want to go to the bathroom, I will get up, I will walk down the hall, my arms will naturally swing, I will take a good stride length, I won't have trouble getting up out of the chair, so on and so forth. I do not have to think about those things to make them happen. They just happen. You have to think about all of those things to make them happen. And it's that extra brain effort, it's that extra thought, it's that extra brain work that I think leads to this mental and brain fatigue. I think it's this extra energy that is required to do everything that really leads to the tiredness. Now, again, you guys can correct me if I'm wrong because you have it and I don't, and I'm just extrapolating from what patients have told me because this is not written about. This is not a textbook answer. This is not in papers. That's just my opinion about where the fatigue is. But I think it's important because in the time that I've been doing this, because that's such a common complaint and difficult complaint, I have tried literally every medicine known to man in the past 10 years, in order to try to treat fatigue, I have tried every medicine you can possibly think of. I have tried more dopamine medicines, including Sinemet and Mirapex and Nupro and Requip and Azilect and Selegiline and Norians and every medicine known to man. I have tried antidepressants, thinking, okay, maybe depression or serotonin or norepinephrine are more the culprit here in terms of this fatigue. I have tried stimulants. I have tried methylphenidate. I have tried modafinil. I have tried, this is Ritalin and stimulants to try to help. And my success with all of these different types of medicines is not very good. I have yet to actually find a medication that really helps with this fatigue. And again, if it were a physical fatigue or if it were a manifestation of depression or a manifestation of dopamine loss, then I think the medicine should help, and they just don't. And that's why, again, I think this is something different. I think this is more of a mental fatigue, a brain power fatigue. And interestingly enough, the only thing, and you guys are going to get tired of hearing this, the only thing that I have ever come across that is, and I see, Donna, I saw you saying it out loud, and every single person here knows what the answer is going to be. The only thing I have successfully treated that brain fatigue and that tiredness with is exercise. I can't explain it. I don't know how it works. I don't know the mechanism of how exercise works, but 10 times out of 10, people come back and say, I feel better when I exercise. It gives me more energy. I don't know how, I don't know why, it just does. Now, yes, it's counterintuitive, right? You're like, I'm already tired. I'm already have lack of motivation. How am I supposed to get up and exercise to make me quote unquote feel better, Dr. Lickletter? What are you trying to tell me here? If I exercise, I'm just going to be even more tired because I'm going to be worn out. I didn't say I had all the answers. I just can tell you what I've learned through experience. And that really is the only thing that I've come across over the past 10 years that has helped with that fatigue. Again, I really do think it's because it's not a physical fatigue. It's not necessarily a manifestation of these chemicals. It's something different that comes about because of how much energy and brain power you have to put into day-to-day activities. And for some reason, getting up, moving, being active, and exercise really does help. Now, obviously, if you're at work, that's not exactly an easy solution. And so, again, if you're coming to me and you're saying, you know what, at work, I'm struggling with this fatigue, I'm going to try a medicine. I'm going to give you a stimulant, or I'm going to adjust something to see if we can help. I just not have not had very much success doing that. But also, again, I don't know, if I'm at work, I can't just go for a walk or go for a run or hit the gym because I'm working. And if that's true for you, then exercise really is not the solution. We have to come up with something else to see if it works. But that was a lot of suggestions and thoughts on that. Hopefully it helped. That's just been my own personal experience. What is the way folks diagnosed with Parkinson's and then seem to be really have PSP are cared for? Is apathy and anxiety indicators and no real effect with Furtari? So I think there was a lot of different questions here, and I'm going to try to tease through them as best I can. So at the end of the day, it's actually not uncommon to get diagnosed with Parkinson's disease and then down the road be like, nope, I think this is progressive supranuclear palsy or multiple systems atrophy or cortical basal syndrome or Lewy body disease. Those are the four so-called Parkinson's plus conditions. And the reason for that is these are called Parkinson's plus conditions for a reason. They oftentimes start off looking exactly like Parkinson's disease, and sometimes they even respond to medicines the same way Parkinson's disease does. And so it is very, very possible in my own hands. I take full responsibility of this, but I don't think I'm alone. I think this is pretty universal. We are invariably going to misdiagnose people until we have a definitive test, until I have something I can show you a picture or look at a blood test. As long as our diagnoses are still based on clinical symptoms, we are going to be wrong. Early in the course of disease, we're going to be wrong a lot. Later in the course of disease, our success gets much better. But early in the course at diagnosis, our accuracy is not all that great. And it's because we're basing our diagnoses on clinical symptoms that are overlapping in terms of nature. And so it's not uncommon for somebody to come to my office and look like they have Parkinson's disease. Now, if you've heard me talk, you know I am slow to label Parkinson's disease. I am fast to label Parkinsonism. And so I kind of cover all bases when I say you have Parkinsonism. That way I'm hedging my bets. It may be Parkinson's disease, it may be something atypical, but I have also been wrong. I have diagnosed somebody with Parkinson's disease and turned out to be progressive supranuclear palsy or these other things. And it's because you can look exactly like Parkinson's disease. You can actually have good response to medicine. I can think of a couple of cortical basal, degeneration patients who really did have a good response to Cinemet, only to then deteriorate and go down pretty quickly. And then I was like, oh, no, I was wrong on that one. It's the other symptoms that come along afterwards. It's in progressive supranuclear palsy to begin with, it's the loss of ability to look up and down. It's the early falls, particularly in the backwards direction. It's a lot of truncal rigidity. These are the things that tip you off in the direction of PSP. But they're not always there when you first meet somebody. And so it is not uncommon to have a diagnosis of Parkinson's disease, only to then turn around and have us change our mind and call it something else. Again, doesn't always happen, and that's not typical, but also not uncommon. And so that's how you could get diagnosed with Parkinson's disease, only to find out later that maybe it's something different. Apathy and anxieties are very, very common and prevalent in all of these conditions. And so statistically, according to papers and everything that I read, it's 50%. 50% of the time, people with Parkinson's disease have underlying anxiety and depression. My personal experience suggested that number is significantly higher than 50%, but whatever, I didn't write the papers. And so apathy and anxiety also go along with the Parkinson's plus conditions, as does depression, including PSP and MSA and cortical basal syndrome, so on and so forth. And so I don't think you can use one as a distinguisher between true or typical Parkinson's disease and say these other conditions, because I think anxiety, apathy, and depression go with all of the above. And I think it goes with all of the above quite frequently, even more than the 50% of time that's quoted in the papers. The lack of response to Rotari or Cinemet or carbidopa levodopa would start to raise a red flag, right? And so if I label somebody as Parkinson's disease, again, this is my own opinion, I am relatively slow to label somebody with Parkinson's disease. But if I label somebody with Parkinson's disease, it's because I think it's fairly typical. And what I mean by that is you have the right symptoms, right age of onset, right presentation, right disease progression, right response to medicine. And so if I have somebody with Parkinson's disease, they should have some response to carbidopa levodopa. And so a lack of response to any version of carbidopa levodopa would really be a red flag and make me think, at least label you as Parkinsonism, not Parkinson's disease, but also then make me think, is this something different? Could it be a PSP? Could it be a cortical basal syndrome? Could this be drug induced or a vascular Parkinsonism? Or could this be something different that maybe the medications are not going to have the same effect? And so hopefully that answered all the questions that were teased in there somewhere or in some way, shape, or form. If not, send in another question. Does Vyalev eliminate the conflict between eating and medication? So my short understanding is Vyalev is the newest version of carbidopa levodopa. It's actually a phosphorylated levodopa that comes in a subcutaneous infusion. So this is the pump that will pump for 24 hours, I think, directly under the skin into the abdomen, a version of levodopa. And the short answer is yes, that should take away the conflict of the eating, although again, it is still absorbed into the bloodstream. So there is still a potential for getting across the blood-brain barrier to be impacted by protein or other carrier proteins. I think it should significantly lessen the conflict. It could take it away. There may still be some sort of absorption problem, but again, I have only used this a handful of times so far. I will have a much better answer for that question after I get to use it a lot more, after I learn all the ins and outs about it and see how it works in a real life patient. And then they will answer that question for us. Again, I only know what the company tells me at this point. I've only used Vyalev, I don't know. I think in our clinic we've used it maybe 5 or 6 times. It's still very early in the course. I still am not able to get it for the vast majority of people. And so I think once I'm able to get it because it gets approved and I can use it more readily, I'll have much better answers for the different kind of ins and outs or pros and cons of the subcutaneous infusions. What do I know about light therapy? And there may be a study at the University of Rochester. So light therapy was looked at it for a variety of things. So it's been looked at for sleep, it's been looked at for fatigue, it's been looked at for mood. And again, I feel like it was maybe 3 years ago, maybe 4 years. I can't remember. All my years run together. I barely know what year it is now. There was a talk at the Movement Disorder Society meeting that I listened to where they were really talking about using a light box to help with sleep and mood and things like that. And there is some literature to suggest that it helps. There's probably some research going on. That's the light therapy that I'm aware of. Now, there's a lot of other types of therapy. There's red light therapy, there's blue light therapy, there's laser therapy. I have not seen good data on any of these things, even though they are also touted, especially red light therapy for Parkinson's disease. I think you can buy it on Amazon. I have not seen good data on any of those just yet. So if that's the light therapy that you're talking about, jury's still out. Again, lack of evidence doesn't mean it doesn't work. It just means that they haven't done the studies or proven that it does. And so in my world, when I'm recommending things, there really has to be good evidence for me to recommend it. That's different than saying, if you want to try it, go for it. There does not have to be as much evidence for that. But just know that if I'm recommending something, there has to be a lot of evidence behind it. So if you're talking about red light therapy, that's a whole different ball game. They're still working on that. But if you're talking about light box therapy, there is some evidence to suggest it does help. But you have to have a certain amount of light. I forget the numbers or certain strengths of light that are really effective and beneficial. Good question. So, husband, 10 plus years into Parkinson's disease, never had a DAT scan or any other test other than walking, fingers, strength, probably all the same stuff I do to my clinic patients every time I see them. I had to ask for an MRI 2 years ago, no tremors. What test should we have asked for? The short answer is I don't have enough information to answer that question. But the longer answer is it depends. If somebody comes to my office with typical Parkinson's symptoms, and I end up diagnosing them as Parkinson's disease because everything is typical, I never actually order a single test on that person. I don't do a DAT scan. I don't do an MRI. I don't do any blood tests. Those do not actually help my cause. Now, that is in the typical person, right? So if that is the typical age of onset, the typical progression, the typical response to medicine, that is the person that I label with Parkinson's disease. If something is atypical, then I might order some testing. Not having tremors is not necessarily atypical enough that I would go order some testing. You can still definitively get a diagnosis of Parkinson's disease even if you never have a tremor. That is not a prerequisite for the diagnosis. But it depends. If really walking imbalance was the primary problem, I would probably check an MRI looking for vascular Parkinsonism. If things weren't progressing well or if things had a problem, then an MRI might enlighten you to vascular disease or shrinkage, or if there was a lot of memory problems or early hallucinations or things like that. Those would be the things that would make me potentially order testing, order an MRI. Or let's say I thought you had Parkinson's disease, and then I put you on carbidopa, levodopa, and nothing happened, which would be atypical response to medication. That's probably the one time I use a DAT scan. And so a DAT scan is a nuclear medicine scan. This is not a definitive test for Parkinson's disease. This is a nuclear medicine scan that tells you that you're in the right ballpark. So it tells you that you have a dopamine problem. But Parkinson's disease and many of the other Parkinsonisms or Parkinson's plus conditions would all show up equally positive on a DAT scan. So it doesn't tell you that it is true Parkinson's disease. It just tells you that you're in the dopamine ballpark. But if I look at somebody and I think they have Parkinson's disease and I put them on medicine and nothing happens, it means one of two things. It either means I am completely wrong and they are not Parkinson's disease and I need to think of it acetylcholine medicines or something completely different, or I haven't given them enough. And that's where I'll order a DAT scan. So if I order a DAT scan and it comes back positive, tells me that I'm in a dopamine deficiency problem. And this is why if you've had a DAT scan, the radiologist will always report it positive for a Parkinsonian syndrome. They will not report it as Parkinson's disease. It at least lets me know that I'm in the right ballpark. I'm using the dopamine medicines, carbidopa, levodopa, pramipexole, ropinirole, Nupra. All of those medicines are the ones I'm going to stick with. Let's say I do a DAT scan and it is normal. That means dopamine is not the problem, and maybe I need to switch gears and think of something else. That's really the one time that I'll use DAT scans consistently. The only other time I'll use a DAT scan, and everything that I'm saying is also true for the skin biopsy and potentially the CSF study, the spinal fluid analysis, but I've never done that one myself. All of these tests tell you that you're in the ballpark. They are not specific or sensitive enough to tease out Parkinson's disease versus Lewy body disease versus any of the other Parkinson's like conditions. Um, The other time I will use these tests is if I'm thinking about surgery, particularly if I'm thinking about surgery in somebody who has multiple different types of tremors or an odd picture, because ultimately that may help figure out where I'm going to put the wire or where I'm going to have the surgeons put the wire. Those are really the only two times you'll see me use a DAT scan. But realistically, so going back to the question, if your husband came to my office and we diagnosed him with Parkinson's disease and everything was fairly typical, I probably wouldn't order a test because it wouldn't change anything that I do, and it doesn't give me any information that I need to help decide what treatment strategy. So that's a tough one. I don't have enough information necessarily to say yay or nay. Any thoughts on why Vyalev has such a high occurrence of hallucinations associated with it? Well, not yet. Again, maybe it's because as an infusion, it's more consistent medication. But again, I think I'll have a better understanding of it in terms of side effects to it, problems with it, complications with it once I can use it more. Um, it could be that, again, since it's so new and we haven't really used it yet, we're not using it correctly. If we're adding it into medicines, maybe we're starting people off on too much, and that's leading to hallucinations. I'm not sure. But these are all things that I think we're going to have to work through as we get to use it more, which again is probably not going to come until Medicare says we can use it. What is the biggest fallacy about Parkinson's disease that comes up over and over again? Maybe that Parkinson's disease is one thing. Maybe that people, and I'm not blaming anybody that I'm looking at right now, but people tend to compare themselves to other people and think that it's the same thing and it's not. That we treat everybody the same, that it's made up. I don't think that's one. I just made that one up. But it seems like that would be a fallacy, that it's all in your head. Nah, that's not true either. Um, I'm not sure, but if you guys come up with them, put them in there and I'll debunk them. But realistically, I mean, there's a lot of things that are talked about in Parkinson's disease that have become just thought to be not true. Um, not just on the scientific level, but on the kind of person to person level as well. Yep. So terazosin, which is a prostate or benign prostatic hypertrophy drug or a urinary drug, might have some positive effect on Parkinson's disease. What is my opinion? So this was looked at in kind of a global study, right? And so at the end of the day, they looked at a population of people and they found that people that were taking this for prostate problems tended to either not develop Parkinson's disease or have a milder course of Parkinson's disease than people who in this population were not taking it. Now, the hard part about this, and you've heard me talk about this before, and if not, this is fun for everybody, is trying to figure out the difference between causation and correlation. And this is why every time you see a study like that, the end of the study or the end result is more studies need to be done to see if this is true. Because when you do these population studies, and it's not just for terazosin, it's been for statins they've looked at, it's been for blood pressure medicines. This is how we found the diabetes medicines that are currently being studied. But you'll notice that none of these medicines have a study yet to date that say, yes, they actually slow down disease progression or keep people better longer. Not yet. They all require further study. And the example that I always give that I actually learned from my neuropsychologist here one day when she was giving a talk is umbrellas and raining. And so this is the correlation causation talk. And so when it rains, people have umbrellas, right? And so if you were an outsider perspective and you were looking at a population of people and you said, "Hey, it's raining, people have umbrellas." If you didn't know anything about rain and you didn't know anything about umbrellas, there's actually two very different conclusions you could come to. You could say, "Hey, every time it rains, people put up their umbrellas. That seems to be the correct correlation, and it seems to be that the rain causes people to put up their umbrellas." However, if you didn't know what you were looking at and you just saw this in a population, you could equally as logically, but also completely wrong, say, "Hey, every time people put up umbrellas, it rains." Clearly, people putting up umbrellas must make it rain. And so you really have to be careful when you're looking at studies and you're trying to say that something causes something. You can note correlations and you could say, when I look at this population, it seems like people who take these medicines don't tend to get Parkinson's disease. But the end result is always this needs to be looked at further in true gold standard randomized controlled trials to know if we're right. And that's what hasn't been done yet. And so they're working on all of these things. They're looking at the diabetes medicines, they're looking at the prostate medicines, they're looking at the statins, they're looking at blood pressure medicines. They're doing this work, but until somebody shows me a study that says in a good randomized controlled trial, we gave so many people this drug, we gave so many people placebo, and these people did better, it's really hard to say with any accuracy or any evidence what's true and what isn't. And so I'm always interested when I see these things, but I don't get overly excited about them until I see good hard evidence or actual data. And so that's kind of my thought on that. And all these other scenarios, which are all out there and you'll read about, but until we really see the data, I don't get too excited about them. What are the options if you can't tolerate carbidopa levodopa? The medication leads to brain fog. Well, and so a couple things. One, as I mentioned, carbidopa levodopa comes in a bunch of different varieties. So I have had patients where if you don't tolerate one, sometimes I can get away with a different one. If you don't tolerate the immediate release, maybe I can use the controlled release. If you don't tolerate the controlled release, maybe I can use Ritari or Crexont. And so sometimes we can switch the version of carbidopa levodopa. But I have had patients that just don't tolerate any of them. And then we start looking at the other medicines. So then we're using dopamine agonists like pramipexole or ropinirole, or we're trying Norians, or we're trying Azilect or Sagilene. We're trying these other medicines to see if we can get better results without having to use carbidopa levodopa. Maybe that would be an indication for these infusions. Maybe it's the pill form that causes the problem, and maybe the infusions would be better. And I have had a patient or two where they just couldn't tolerate any of the medicines. And so we ended up doing deep brain stimulator surgery and it helped. And so again, just because you can't tolerate carbidopa levodopa doesn't mean you can't do anything. It just means that the best medication that I have, I can't use, which definitely puts us behind the eight ball, but not impossible. And again, just like everything else, we're going to work with you. We're going to work around what you can and can't tolerate, and we're going to try to construct or come up with a good game plan to see if we can get you doing better, just like I would do for anybody else. It just means I don't have access to the best medication that I have, which makes it tough, but not impossible. And those would be some of the strategies I would think about to see if we can get you doing better. I mean, maybe if it's higher doses that you have problems with, maybe you need lower doses more frequently. Again, there's a lot of things we can try, but much like everybody else on this call or everybody else who comes to my office or everybody else who's been dealing with this, it just comes down to a whole lot of trial and error. We try one thing. If it works, great. If it doesn't work, we backtrack and think of something different. There's no visible on or off times now taking 2 carbidopa levodopa 4 times per day in a slow release overnight. Why not just 3 times per day taking the 5200? So, uh, and I get at this question, there's nothing that says you couldn't. So you can use the controlled release carbidopa levodopa during the day. The other part of the question would be why not, because if you're my patient, you've probably seen this, but if not, you may not have seen it. I don't know how other people work, but I like to use the 25-100 carbidopa levodopa immediate release, because in my experience that really is the best pill. So you'll see me have people take 2 pills a day, 1.5 pills a day, 2 pills 4 times per whatever, 2 pills with a dose, 3 pills with a dose. It does come in a 25 250. Why don't I just use the bigger pill? And it's because experience. In my experience, it just doesn't work as well. Does that mean that's fact? No. That's probably just my opinion and my experience. The same thing is true with using the controlled release during the day. There's nothing that says you can't. Controlled release Cinemet comes in 25-100 and 5200. And so if you're taking the immediate release 2 pills 4 times per day, why not just use the controlled release 5200 3 times per day? You can. There's nothing that says you can't. It's a lot of trial and error. Again, in my experience, the controlled release just doesn't kick in as well. And so at the end of the day, the immediate release people like a little bit better because they feel it work, it kicks in, and they like to feel that. But that's not true for everybody. That's not a universal. As you have found or as you've seen, nothing I say is universal. Nothing I say is what's true for every single person. I have people that like the controlled release and I use it during the day. I would say I have many more people that use the immediate release, but that's not written in stone. And these are all questions to bring up in terms of what can we try? How can we manipulate things? How can we change things to see if we can get the best possible result? My goal when you come to my office is not to just give you my version of medicine or what I think we should do. My goal when you come to my office is how can we work together on this? How can we work on getting you to be able to do the things you want to do as well as possible, as long as possible, preferably on as little medicine as possible. That really is my game plan when you come to my office. And just because what I typically do is what I typically do for the majority, that does not mean that it's the right plan for you. And so bring up these ideas if you have thoughts. And it's not just me, that you should do this with whoever your provider is or whoever your neurologist is or whoever your doctor is. They should not be hurt if you try to help them or guide them or say, "Hey, what do you think about this idea?" If they get mad when you try to suggest things, then maybe you should see somebody else. Unless it's me, in which case I'm sorry. I was just having a bad day. But at the end of the day, it's a conversation, and we really should try to work together on what we can do. Has the decrease in funding by the government negatively affected Parkinson's disease research that was promoted by the previous administration? Probably. I mean, I don't think I'm going out on a limb on that one. I don't know of any research. I couldn't cite a specific research study or location or something that I thought was going to happen that's now on hold. I mean, I can't tell you anything specific, but at the end of the day, just based on what I've heard in terms of how they've cut research funding to big academic institutions to everybody, I mean, it has to have a trickle down effect, would be my guess. I have not heard of anything specifically in the Parkinson's disease community, but I would be surprised if the Parkinson's disease community was immune to this. Again, at the end of the day, I don't think there's anything special. No offense to you guys. I don't think there's anything special in the research community about Parkinson's disease compared to any other neurological or non-neurological condition that's going to get you preferential or special treatment. And so my guess is because the cuts from what I've heard have been pretty much across the board, at some point in time, it's probably going to impact a Parkinson's disease study or research program at some point. I haven't heard about anything specific yet. If I do, I'll let you know, or if you hear about anything, let us know. But I would just be surprised based on how the cuts went that Parkinson's disease research is not affected. And so again, that's kind of the best answer that I have for that. I am not currently participating in any research trials. I have a couple that I think have already finished up. One might still be open, but it's not enrolling, and none of it's funded by the government. So I don't have any personal experience with that. But again, I'm sure it's being impacted. And with that, Casey, I hit the bottom and I'm 4 minutes early, which will probably
Wow.
never happen again. But my guess is people were
Well,
all saving their questions for Saturday.
oh, that's true. I think Donna may have had her hand raised.
Did I miss it?
Donna, do you
It's
have a
possible.
question?
Yeah, I was just typing it in here.
Okay.
I'll read it what I was typing in.
Sure.
I think the biggest fallacy, inconsistency in Parkinson's disease is the hypothesis that the PD is a lack of dopamine. Other people have expressions that it's an excess of dopamine, and other people think it's not a dopamine problem at all. It's a stress condition. So, and I think that using levodopa to confirm, giving people levodopa to confirm the diagnosis if they respond to it. I think a healthy person would respond to dopamine. Everybody needs more dopamine. And to treat it without doing any other test is dangerous, and it may be preventing the body from healing through a whole body approach. And also, and I want to bring this up to Casey, I brought it up earlier, prescribing levodopa, and if you happen to be getting yellow levodopa pills, they have contained yellow number 6 and yellow number 10, which is known to have a cadmium, known to have a contaminated with cadmium. So you're giving people more heavy metals into their system when we think that this may be the cause of Parkinson's, and we're feeding them heavy metals in yellow dopamine pills.
And none of what you just said has any evidence to back it up, but that's okay. Whereas there are plenty of studies on the use of carbidopa, levodopa, and how it is definitively the gold standard for Parkinson's disease, but that's okay.
It's the short fix. It's
the
a short fix that leads to dangerous side effects.
It does have complications, but it is still the gold standard medicine for people with Parkinson's disease.
And what do you say about it containing yellow number 10 and that has a cadmium?
It's definitively a yellow pill, but what is the side effect to it that you're talking about? What's the toxicity of cadmium?
It's a heavy metal.
Okay.
Causes Parkinson's. Causes a lot of disease.
Such as?
Parkinson's, ALS.
There is no evidence
MS.
that cadmium toxicity causes Parkinson's disease. Show me the study on that.
Well, don't they have heavy metals as the cause of Parkinson's? And
we don't know the cause. So the biggest fallacy that you're hinting at is that we don't know why people have Parkinson's disease. We do not know that heavy metals directly lead to Parkinson's disease. There is no study out there that suggests that heavy metals is the cause of Parkinson's disease. You prove me wrong. At least not a good study. And so the biggest fallacy is that we understand Parkinson's disease. That's probably the biggest joke, because we don't. We do not know what triggers it, what causes it, what leads to it, what adds up to cause people to get it. So that probably is the biggest fallacy.
You know, but the people that are getting better, the first thing they have to do is get off of levodopa.
Show me the evidence on that.
Well,
show me the gold standard randomized controlled trial that people get better off of carbidopa, levodopa. I would love to see it.
Well, when you think about DBS, one of the main side effects, I mean, that only works for a while too. It doesn't work permanently. But one of the main advantages of that is you can definitely reduce your amount of levodopa if you can. That's the goal too, is to reduce what you're taking. Why?
That is definitively not the goal of DBS. I don't know who told you that. The goal of DBS is never to decrease medicine. The goal of DBS is to help you do better, which often requires both medication and stimulation. Yes, a lot of times we are able to cut back medicines, and that's one of the benefits, because that takes away some of the side effects that come with the medicines. But that is in no way, shape, or form, at least in my office, ever the goal.
But people that do have a positive response to DBS usually can reduce the amount of levodopa they're taking.
Correct.
And that seems to make all the difference.
No, that's just one of the beneficial side effects of DBS. The benefit is because the stimulation is helping, not because we're taking away your medicine.
Then the other question I have is, if it is a stress condition and you're feeding the whole body dopamine, not just the brain, and you're doing it, and then the excess of dopamine, you're fooling around with the body's natural dopamine system. And if they're stuck in a flight, fright, and freeze mode, then the excess dopamine that you're feeding them turns into adrenaline and keeps the body in that non-optimal state. They can't absorb nutrients. They can't do anything. So that's what's leading to Parkinson's, not just, you know.
I'm glad you have solved Parkinson's disease. This is great. Again, I just need to see the studies that back this up and prove this. There are a lot of theories out there, don't get me wrong. And you are saying some of the theories that are talked about in Parkinson's disease communities, but these are not proven. We have not solved Parkinson's disease. And so again, in 10 years from now, 15 years from now, 20 years from now, we may have all the answers that you're mentioning, and you may very well be right, but it is not proven yet.
But don't you feel bad about giving levodopa? And if it is proven that it's dangerous, how will the neurologist feel about that?
I will sleep perfectly comfortable at night knowing that I did the best I could to help my patients feel the best they can. And as far as we know, multiple studies, gold standard randomized controlled trials have suggested that carbidopa levodopa helps people do better. That is as fact as I can come up with. So I'm going to feel great knowing that I did the absolute best I can to help my patients function as well as they can and feel as good as they can, regardless of what comes up in the
How
next 5,
long?
10 years.
How long? How long do they feel better? And there's
It's
no,
variable.
yeah,
It's variable.
it's not, there's no gold standard studies that levodopa is the answer in the long term.
There is no answer in the long term.
So how can you even do a study?
Great question.
Yeah,
I'm open
really.
for suggestions.
Yeah. More to come on that. Perhaps we'll leave it at this for today.
I think so. We can
Yes.
talk about it more.
We
But
can
maybe
definitely.
this will be and again, this is just my opinion. Maybe this is a great question for Saturday when we can get other people's
Mhm.
thoughts on this.
Did you know that yellow dopamine pills contain a cadmium component to them?
I assumed it had yellow dye. That's why they're yellow, but I couldn't have told you that it had cadmium in them.
I looked at the synthetic color and what it's prone to be contaminated with, and they say, and it's only approved for yellow number 10 is only approved for drug and cosmetics. So if you're breaking up the pills, and there's a cadmium influence through the skin because it's not even approved to be digestible, yet they put yellow dye in pills when it's not in food. But these pills are being taken over 20 years. You know, it's not a small amount. So I think that's really dangerous.
Adele had mentioned how much, so maybe that's something we can explore and touch on next Talk with the Doc. And if you come to the conference on Saturday, you'll have plenty of time to ask questions. We will also record it. So if you miss the conference, the presentations will be on our YouTube channel. And we'll have to touch on the medical marijuana question next time, William. For today, that's it. We'll see you on June 5th if we don't see you this weekend. Thank you, Dr. Leichliter, and thank you for everyone attending today.
Thanks, Casey.
Thanks, guys.
Thanks,
You're
Dr.
welcome.
Al.
Bye.